Thank you very much for coming to our second Feature Spotlight webinar. It's very nice to have you all here. Just to run you through the agenda that we are following for the next 45 minutes. We will move over to, we'll have a presentation from Lucy and Louise, who are our colleagues at West Herts, who have been running the Deteriorating Patient project. We'll then have a live walkthrough and product demonstration from Tim, and then we'll have a Q&A session at the end. So feel free to pop any questions in that you have throughout the session, and we'll hopefully get through them all at the end. Just a little bit of housekeeping. We have put everyone on mute just so we can hear all of the speakers nice and clearly, and we are recording this session, so if you would like to turn your camera on so we can see that people are behind those cameras, that's great, but we appreciate that you might not want to be on the recording. So without further ado, I will pass over to Lucy and Louise.
Thank you very much. Yes, so hi, I am Lucy, and I am one of the Associate Directors of Nursing here at West Hertfordshire, and my area of expertise is around the deteriorating patient. And I am here with my amazing colleague who I couldn't do anything without, so I'll let her introduce herself.
Hi, I'm Louise Bradbury. I'm the acute care response team here, lead here, not the entire team, myself. I am the lead here at West Herts. So yeah, we're very excited to share what we've been doing with you guys.
Amazing. Tim, if you can put up the slide. I guess really setting a little bit of a background scene, and that's really what we're going to do over the next couple of slides for the ultimate rationale for why we've undertaken the project we have, and really how Alertive has allowed us to build confidence in a system that ultimately you want to be as confident in as possible, because it means so much to our patients and our patients' outcome. Essentially, the slide speaks for itself. So when time isn't on our side, our systems ultimately must be. And it is actually really true. I constantly talk about how we are on a mission here at West Herts to remove hurdles, remove barriers, and ultimately make our tools as safe as possible and as fit for purpose for our patient population. Tim, if you can. So I guess, like most organisations, I would say we are not unique in the sense that we often see episodes of deterioration with our patients. We are an organisation which are within pretty much the 80% of organisations in England who have adopted the gold standard of News 2. And we ultimately use an EPR system here, which our News 2 is built into. And really, we were seeing inconsistencies with compliance with our News 2 surrounding escalation and response. But also we were seeing huge gaps between, were we escalating to the right people at the right time? Were we getting the response we wanted to see from people? Were people putting this as a priority, or were there competing priorities, which meant that actually when we were calling for help, we weren't always getting what we needed to the patient when we needed it? So we spent a long time picking apart lots of clinical incidents here within the organisation, and like a lot of organisations who've been through the PSURF work, we undertook a thematic review, and really some of the big things that came out were delays we were seeing, staff overall confusion, and a general sort of lack of confidence or a lack of empowerment within our staff to go above. So often, I'm sure that many of you on here will be used to this. It's quite common for staff to feel confident going to somebody they're familiar with, but once they have to go higher up that tree or that ladder of seniority, people suddenly feel slightly more uncomfortable. We have a traditional bleep-based system here, and we were seeing issues where bleeps would go through, some bleeps wouldn't go through, some numbers wouldn't show. You had no visibility, you had no idea if the end user had got this bleep, and therefore people were feeling quite isolated and alone with patients who were quite sick. So just a small sort of statistic, I suppose. So we looked at a 6-month period on our EPR system, and we had something just over 37,000 News 2 triggers. So they were 5 to 6 or 3 or more in one parameter or over a 7. And we had only 7,000 of them had an actual documented escalation piece, which, you know, when you're undertaking investigations and you're looking into what has happened for this patient, it's really challenging when you're looking at a blank screen and you've got nothing to work with and you're trying to piece it together. So I guess for us, we took essentially, you know, we were really keen to think about how could we tackle what I often look at is a really I guess an unmeasured cost to us. It's an unmeasured cost to our patients, and an absolutely unmeasured cost to our workforce, and how it leaves them feeling in scenarios where there are delays, where doubt is there, and communication is not as strong as it needs to be when it needs to be. We had a huge amount of staff that we surveyed who found that, you know, responses were delayed, and and it was happening really frequently, and that was hugely impacting on the patient care we were seeing. And quite worryingly, 35% of those people felt that actually our escalation process, despite using this gold standard that was meant to be the saving grace and sort of really change the way we escalated and responded to deterioration, it was still felt actually within our trust that actually it was still ineffective despite how well embedded and adopted it is. And I think probably the scariest thing for me is that whenever I've been in a scenario where I've been with somebody who is really sick and I'm thinking, oh my gosh, I just need that one magical person to walk in this room right now, and I know that they're going to absolutely turn this around and it's all going to be fine. It's that feeling of not knowing if you are going to get that right person walk into that room, or even if they've even got the information they need to action on your behalf. So I guess, yeah, so next slide. Sorry, Tim. I think then I'm going to hand over to Louise, who's going to kind of talk about how Alertive came in and how they became our knight in shining armor.
Thanks. So yeah, as Lucy sort of alluded to, our EPR system, we have News 2 built into that. And we have OBS machines as well, that when a member of staff does the patient's observations at the bedside, those observations automatically get uploaded to our EPR system. The system automatically calculates the score. So we kind of have taken out nearly all of the sort of human error things that could potentially go wrong in that process. But what the system wasn't doing for us then was actually, that's where the process kind of stopped, and then you go back to relying on a human to have recognized that this is something they need to escalate, to be able to have the time to go and make the escalation, and then also have the time and awareness to make sure that the response comes, because again, we all work in busy areas. A lot of our ward areas only have 1 or 2 phones available, so if both phones are in use, straight away you've hit a barrier because you can't escalate to the person you need to escalate to. So within our EPR system, it does generate an alert for a triggering news score, but that alert only goes to the person who has a relationship with that patient, and it only comes up when you log into that patient's record, so nothing gets sent as a sort of automatic escalation point. So basically that's where Alertive came in for us, and because we wanted a system that would, once that higher news score was built in and recognised within our Cerner system, we needed a system then that would automatically tell the people that needed to know about this news trigger. which is essentially what they have done for us. What we've done is we've built specific pathways within, well, I say I haven't done any of the building, if I'm being completely honest. They could take the credit for their side. But what it's enabled is that we can create groups for various escalation pathways. So for a news trigger of 5 to 6, the alert goes to a defined group of people. So it will go to the nurse in charge of that bay. It will go to the nurse in charge of that area. And it will, when we get this part of the pathway built, it will go to the resident doctor. For newses of 7 or more, it goes to the nurse in that bay, the nurse in charge, but it also automatically comes to my team, the response team. So straight away, the staff in that area have that reassurance that even if they're in a situation where they're busy, they can't get to a phone, they can't get out of something that they're doing, they know that those scores have automatically gone to somebody. So somebody already knows something's happening with that patient without them having to actively do anything. And within the system as well, you know, when the alerts come through, it's amazing because you can see who it's been delivered to, who's read it, who has responded to it. So there's a real traceability, and again, really gives staff that reassurance. Not only has that alert gone, but they know that somebody has seen it and somebody has either said, yes, I'm coming, or no, I can't. You need to make sure somebody else deals with this. So it's kind of really, it's streamlined the process. It's made it a lot less prone to human errors, and has kind of given us a much more reassurance about our escalation process. You want to move on, Tim? Thank you. So how it's changed practice. So I've kind of explained the process, but again, it gives us I think it's within 60 seconds. And again, the technical alertive team can tell us if that's right or not. Those alerts go out within 60 seconds. So it really has completely almost eradicated delays in an alert being raised for a patient who triggers a news score. We haven't got a huge data set at the minute, so we haven't got enough data to be able to really show a trend in what that's meant for patient outcomes. But what we can absolutely say is that staff feel much more confident about the escalation process. They feel much less anxiety around the whole process, much less they have much less concern because they know they can instantly speak to the people that alert has gone to. So there's an instant messaging function within the alerts. So like I say, not only do they know that, you know, say I'm clinical that day, I've received the alert. If I can't go, they will know instantly that I can't go and that somebody else is either going to come instead or that they have to take that somewhere else. So it's absolutely improved their confidence. It's given nurse in charge as well, and, you know, a much better oversight of what is going on in their area. So we're trialling in our acute admissions unit at the moment, which has a really high turnover of patients. It has some of the sickest patients in the hospital outside of ITU because it's where our patients kind of go from ED into our acute assessment unit. You know, so these are potentially quite vulnerable, sick patients. And so the nurse in the overall sort of coordinating nurse in charge for that whole area, it's given them a much better oversight of what is going on in their area. And again, they then have the ability to be able to know where their resources are best served. So if they see an alert come through, they are there in that bay, in that area, checking on the staff, making sure that is there anything that they can do to support them whilst they're waiting for the response team to come and things like that. And then the flip side of...
I think I was just going to say, Louise, I think something that we found that was kind of maybe a bit more like we weren't really expecting was the feedback really from our healthcare support workers. So in a lot of organizations, they are the primary individuals undertaking clinical observations, and the feedback from that group in the way that this system has lifted that burden of them feeling like they're holding this information and they don't necessarily know what this information means, but they know it's generated a number which they must find somebody and tell them about, and then they've not been able to find the right person to tell. I think the feedback from that group has been really great. And it's really interesting because it was kind of a group that we we anticipated around the team leaders and the impact for our nursing staff, but perhaps hadn't really appreciated such the positive impact it was also having on our unregistered healthcare support worker staff.
Yeah, definitely. And I was just going to say then, from the other side, from my team's perspective, as the people that have to provide the response, it's really improved how they can prioritize their workload. So, because again, you know, if they are unsure about anything in the alert, they can instantly contact and have a conversation with the nurse looking after that patient. And equally, the staff on the ground level where the alert comes from, you know, quite often they will message as soon as the alert comes through to say, doctor already with patient. And that's it. And those few words straight away, my response team know, okay, well, I don't have to rush from where I am now. I've got a bit of time. So across the whole spectrum, it has massively changed and improved how we recognise and respond to our deteriorating or our potentially deteriorating patients. Next one, Tim. So yeah, so I mean, this sort of basically just sort of summarizes what I've said, really. But it really has made a huge difference in the confidence of our staff. And I think, like Lucy alluded to earlier, I don't think that should be underestimated as an outcome, because I think anybody who's clinical will have been in a situation where they have fell out of their depth, or they have felt maybe they should have done something differently or done something better, and you carry that with you. Like, that doesn't ever leave you, no matter how much reassurance you might get from somebody else. So in this context, it really has made a huge difference to staff just feeling a lot more relaxed in these situations. So then if the patient is really unwell, and when you do arrive, that member of staff, their anxiety level isn't up here, it's down here. So your communication is better when you get there, their ability to problem solve before you get there is improved. And like I say, you know, it's just made the whole process a lot smoother and a lot less prone to human error. And again, with the doctors' side of things, you know, we haven't got them involved in our pathway yet. That's coming a bit later. But even in practice now, just having this escalation pathway on the nursing side, it makes their workload much more straightforward, and it's become much clearer to the ward staff who they need to escalate to the doctors and who we are going to come to see. And so you're not doubling up on workload and the response team and doctors turning up at the same time to the same patient. You know, so from a resource perspective, it has improved how we utilize our resources. And then again, just anecdotally, I mean, you know, we've always worked quite closely with the teams on AAU, but through the development of this project, the relationships really have become quite solidified and quite strong. And there's a real sort of mentality of, you know, we're in this together. And, you know, with any pilot, whenever you introduce anything new in an area, there's always anxiety around, oh, is this going to be more work for me to do? Is this just something else I have to add to my to-do list? But the staff on our IAU have been absolutely phenomenal and have completely embraced it, been really open with their feedback, really honest with their feedback. So we've been able to make the changes needed to improve the system and how it works before we roll out trust-wide, which again is really important. It's much easier to tweak small things now that will end up being big things once you roll it out wider. So I have to say they have been absolutely phenomenal. Back to you, Lucy.
Thank you. No, thank you. Yeah, so I guess for us, like, yeah, what is next? What is next for us? Probably a lot more work for the Alertive team, because every time we see a new feature, we have a new idea. But they're smiling still, so it's okay. Yeah, so the important things Louise has touched on, we haven't gone live yet with our doctor pathway, and for us, really the delays around that are they're two-part, because to do this we needed absolute buy-in. So we needed that buy-in from our medical colleagues, and the great thing about News 2 is that everyone already buys into that as a concept. So for us, it was really just ensuring that they were comfortable in how we were translating that into the digital system. So that buy-in we achieved, which is fantastic. And now we're really just looking a lot to do with the scoping work and how those roles will integrate in, and the escalation pathways and how they'll work. So there's a lot of work there on the alertive side, and some more work to be done on our side about identifying all the roles and how they'll work. So I'm just kind of going to skip around on my points here, but for us this week, we've seen, a huge spotlight on maternity services in the country. It's the big elephant in the room for a lot of organisations right now, and for us, our maternity services are a really high priority to embed this within our system for them. So our next piece of work will be looking at how we translate our meow scores, and how that alertive piece works with BadgerNet, and ensuring that we can essentially translate the same pathway that we have built within our adult services within our maternity services, because that's the great thing about the way it's been built. For us, the pathways are the same. The bits that are changing are the roles that sit within the escalation points. So we were really careful to create something that was almost like a blueprint, but it was the blueprint to all escalation pathways, as opposed to we have one thing that we do for adults, and then we have to create a whole new system for children and a whole new system for maternity. We were really keen not to do that, because we knew that we could do this in this way with alertives. That was amazing. So yeah, maternity for us will be the next big thing after we've integrated our doctors. And really, I guess for us, it's just ongoing feedback, refining what we've been building, really listening to those users on the shop floor. They've been really central to this build, and their feedback has been really valuable. And actually, we're really excited. We've put a lot of time and effort into this, and we feel really privileged that we've been shortlisted for a HSJ Patient Safety Award for the pilot project for this, and we're really excited about ultimately the impact that this is going to have on patients, and in such a positive way. I feel like often in healthcare we come across digital solutions that often make more problems than they solve. And for me, this is the first time in a long time that I feel like I've used a technology that actually feels like it is actually making a difference. So I feel really privileged to be on the team in hope and in designing this, and and rolling this out. But yeah, that's all I have to say.
Guys, amazing. Like, thank you so much. Phoebe, am I meant to join in at this bit, or are you meant to join in now, or am I meant to do it? I'm meant to do it. Okay,
definitely,
that's good. Okay, well,
definitely your skills there, Tim. So I'll leave it to you.
Okay, wonderful. How am I meant to follow that though? I mean, Louise, Lucy, incredible. I know it's really easy for me to say, but like, I mean, you guys know this already, but like genuinely, it's such a pleasure working with you. And ultimately, I think just to kind of borrow your analogy there, Lucy, about us being kind of the knight in the shining armor, I think that's false. I think we might be the armor, but like you guys are the knight that's delivering this. Like we're simply the tool, and you guys have done this. You guys have delivered this. But of course, we're super proud of our tool and its place in it. So, thank you for choosing us, and thank you for all the hard work you've put in on your side to deploy it. You guys deserve that award. From my side today, I'm sure that you guys are going to have loads of questions about all like that really useful information that Louise and Lucy have just shared there. What I'm going to do is not get in the way of that, actually. And I think those guys have given you a really comprehensive view of like how the technology is working for them and whatever else. And I'm keen to give everybody a good chance, good opportunity for Q&A at the end of this session as well. So I'm going to move fairly swiftly through. Neither my colleagues at Alertive nor the ones at West Herts will believe that, but I'm going to move fairly swiftly through here. So First, just a very brief introduction to Alertive. I'm sure most of you have met us. I'm sure we've been lucky enough to meet many of you before, but for those that haven't, we're Alertive, and we're a company that's built a system which is designed to improve communication for healthcare workers, very much addressing some of the key issues, like the key technologies that have been used, like legacy technologies that have been used in healthcare for a long time. So looking to drive improvements in those. And just kind of like a bit of state of Alertive at the moment. So we're now live at 39 hospitals, mainly around kind of bleep replacement, clinical messaging, but also, of course, lots of the cool projects such as this. And from a scale perspective, we're fast approaching 60,000 users on the platform, millions of messages, millions of alerts sent through the system. So really robust, really well proven with our customers. So in terms of the product itself, from a high level, before demoing, just again as an aid memoir for those that have seen it before, for those that are new as an introduction, we really like to divide the product into kind of like these 5 key tenets that we have. So really our system has an alerting capability, and that capability is designed to provide critical notifications to people, addressing all the issues with legacy systems such as pagers, bleeps, and whatever else. It has a messaging capability for kind of that less urgent but also important secure chat. So this might be where consumer messaging apps are in use at the moment, for example, but again addressing the issues with those around security and around protecting staff time and reducing stress, etc. We have a really rich roles capability, which replicates how staff work today and really empowers, as you'll have heard from Lucy and Louise there, what they're doing, and ultimately our integration capability in here as well. And actually, I'm going to pull a couple of these out as part of the demonstration of what we've done for the guys at West Herts. So integration and automation, I mean, I think that deserves its own slide here, really, because of the capabilities it can bring. But I'll come into that a little bit more. And finally, doing all of this in a compliant way. With those 39 customers, of course, we're DTAC compliant. We've done DPIAs for each site. We've got DCB 0129, etc., etc., etc. So doing all of this in a way that's compliant. So let's actually show you some product here as well. So assuming everybody can see my screen coming through, okay, just to describe my setup really quickly. So first things first, over on the left hand side, I've got a little iPhone here that I'm just mirroring up to the screen so you guys can see that. I've got a little Android device here as well, and over on the right hand side is our web application. And what I first wanted to do here was just kind of show you some of the building blocks within our system that have been really key in terms of the deployment of the system at West Herts and other projects that are semantically similar. So the first one of those is roles. So as well as being logged in as an individual user, as me here and having my own inbox with chats, alerts, tasks, messages, whatever else, our system also has these special accounts that are called roles. I'm logged in here as the anaesthetic consultant as well as me. And the anaesthetic consultant here has their own inbox with chats, alerts, tasks. So any messages sent to this role, I will receive them. And what I can do is at shift handover time, I can, for example, relinquish this role. So if it's a daytime role and a nighttime role is going to come in and take over, I could relinquish this role, i.e. like leaving the device on the table. Or, for example, roles can be given and taken between users. So I can search for my colleagues. As you can see here, we've got availability in the system as well. So I can see whether users are currently logged in or not before I do activity with them. So in this case, I'm going to give this role over to my Android device here. You'll see it appearing on the screen, and you'll see that persistence in here of those messages in that handover. So roles are incredibly powerful for that persistence in handover, for users not having to know exactly who they need to contact. So I don't need to know it's Lucy or Louise. I can know that it's, you know, the rapid response outreach team lead or something like that in there. So I can know that I can know the role instead of the user. Also really important for a project like the West Herts project, like deteriorating patients, in that what it empowers us is for these system-based integrations. When we're creating alerts, again, we don't have to know too much about the individual, the user. We can understand a role which is location-based or team-based, for example, and be able to send alerts out to them. So this has been real key. The other piece that it also provides is, and I'll show this during an alert as well, is it provides other people within the organisation the ability to see the operational readiness of roles and roles within teams at a real glance as well. So instead of having to do like a daily test call or a test call at shift handover, for example, being able to just look into the system and have that visibility of operational readiness. Also, the second feature that's been really key in this project is our alerting capability. So the ability to, in this case, I'm going to put these devices on silent, do not disturb. The Android device is already on silent, limited 4G coverage. In this case, I might want to create an emergency alert to individuals, users, teams, roles, whatever else. I'm creating one manually here. We could say this is a resource call, and it's in adult ED. Forgive my typos, brevity, bad examples, etc. We might want to send down a request for ETAs, record audio, etc. When I create this alert now, like so, what you'll see here straight away between the bleeps is that we can override those volume settings on the devices, fully approved by the manufacturers, to get these alerts pushed through when they're critical. We provide this view of whether alerts have been received, read, or responded to, and we give users a really clear view of the alert that's been sent through with really clear response options again. So being able to have those natively on each of the devices and get those responses pushed back in here to the alert. The alerting capability is for critical communication. Obviously, it shows the status of users, the status of the alert, and it re-pushes undelivered alerts as well using Wi-Fi, mobile data with backup to SMS. So a real critical capability in here. And then the final piece, which is a little bit harder to show you, is our integration and automation capability. So this is, we have comprehensive and rich capability to interrogate or interact with other systems, whether that's EPR in this case via their API or via HL7 messages, whether it's via the Trust integration engine, which might already be consuming messages and notifications, or whether it's utilizing our API for internal development teams that you might have, given the capability, capacity to do so, to be able to utilize our API to send alerts. So in this case, what we have done is we have integrated with the Fire API on Oracle Millennium. And to illustrate that, what I've got here is I've got some third-party software which I can use to instigate our API. So effectively, Louise was right, effectively we're polling the Fire API every minute. On that Fire API, Oracle exposes the discern notifications for the patients that are alerting, and we consume those and generate an alert into our system. So this is basically a way for us to instigate one of those ourselves without using the EPR. So in this case, I'm going to send an alert through of a deteriorating patient. So you'll see and hear that arriving on my mobile device here on the left hand side. So what I've done there is, as you can hear, we've got the ability to override the volume settings still on the device, and we get this interactive push notification here at the top, which excuse me, is scrollable, and I can see all the information in there already, or I can go into the alert itself and be able to see the information. So I've instigated the alert from another system. The important thing here to say is that this is completely configurable to get the behavior that you want. So for example, if we want high alerts to override the volume settings given their urgency, if we want them to be a certain color, we can do those things. Whereas if you wanted medium or low alerts to have a slightly different behavior when they arrive, so we're not battling too much with like alert fatigue, etc., then we can configure those. We can configure those too. So really configurable. In the alert, we get a really clear patient banner. So this is where, so when we send the alert out, before we do that, when we see the alert, we query for patient data. So we look up the patient's demographics, we look up the patient's location based on their encounter, and we bring that information in here to populate the patient banner, and then also to include in the alert itself the observation data too. So we can see the patient's score, we can see the patient's location, we can even pass through the observation data, which is actually caused that new score as well. So we can pass that through, and also advice and guidance for the practitioner that receives the alert, so they know that they don't have to continue with the escalation. They can see that the system's doing that for them. Users can respond to the alerts coming through. So in this case, I've put attend and unable in here. So I'm able to tap attend, and we can actually push that response back into the originating system as well. So given the right place for it within, in this case, Millennium, we can push that response back. So not only do the other participants of this alert have a view of what's happening, but we can also record that then in perpetuity into the EPR. As the guys said, we can see all the participants of the alert can see each other's responses in here. So again, if I'm on the nursing staff, I'm able to actually see whether the doctors have received this as well and intend to respond. So really kind of going back to Lucy and Louise's points there in terms of having visibility at the point of care, having visibility whether somebody is actually on their way. I've not got to go away from the patient, make a phone call or anything else like that. So really providing a view of that. And we've got chat in here as well. So on the Hoof, being able to share, securely share text, voice recordings, images, videos as well in here. And then finally, so from this alert, obviously I've received that, I've responded to it, we've got the chat, we've also got the ability to then push that data back or transcribe it back to the EPR at a later stage too. But also our system is fully auditable too. So all of this information, everything that's going through the system is being recorded in a fully auditable way. So providing you with dashboards to be able to see data in here, to see everything that's happening within the system, but also having that as real auditable data for you guys to be able to get back to at a later stage. So I think the final important thing for me to close on here is, so we have some key capabilities around roles and alerting and our integration capability, which has ultimately enabled us to deliver this requirement for the guys at West Herts, and a load of other benefits that come along with that around visibility and auditability, etc. However, this is just one example that we're only utilizing one capability of the Oracle API here. There are many others, so including things like admissions or lab results or orders going through those systems where we're able to do the same thing. We're able to watch resources on the API, and we're able to generate alerts and messages around those two on-call roles in an auditable way with all the information passed out there as well. So there's lots more we're exploring with West Herts, who are really leading the way on this, and lots more that we're exploring with our other customers as well around other potential use cases, and of course against other systems too. So I'd like to thank you for listening to me in this case, and of course we're going to share we can share more information about this at afterwards. If people want more information, want to set up a technical call, see things in more detail, and of course we'd be delighted to do that. But enough of me talking. I'd love to hand back, and we can pick up any questions that anybody's had. Thank you very much.
Thank you very much, Tim, and thank you, Lucy and Louise. I'm not quite sure how to follow that, but so we'll move on to our Q&A session now. So I think we've got a couple of questions in the chat. So if you'd like to pop them in the chat or raise your hand while we're waiting for your questions, we will just touch on Ian's questions. So Tim's actually covered which EPR we're currently working with, and that is Oracle Millennium. With Cerner, with West Herts. Lucy or Louise, I think the next two questions are probably kind of aimed at you. So what is your CCO service 24/7, and how many per shift?
So we literally launched our new acute care response team model about 5 weeks ago. So we are 24/7. We had a 24/7 critical care outreach team before with one practitioner on, and we had a separate hospital at night team with one practitioner on. But we've kind of amalgamated those two teams and kind of developed the team, expanded the team, and broadened our sort of scope of what we'll do. So now we are still 24/7. We have 2 practitioners on during the day, 2 practitioners on at night, and we also provide Monday to Friday night cover on our elective site as well from next week. So yeah, we were quite lucky we were able to sort of expand the team, because and a lot of that was to do with this alertive project, because once we do go trust-wide, you know, we were sort of anticipating quite a significant increase in our workload, because you know, like I say, you're going to guarantee that you're going to get all of the high news score alerts coming through as referrals, and with just one person on shift, that just wouldn't have been doable for us. So that was a big driver for us expanding and changing the way our team works.
I think as well, it's worth saying, even though we've expanded our team model, we thought also a lot about what we consider to be treatment windows within this system. So even if a patient, say, for example, scores a 5 to 6 on their news score, the way the information, the way our Cerner system is set up, our EPR, there is then a delay. So if they continue to score between a 5 to 6 for a period of time after that, an alert is not automatically generated for every subsequent score unless the score goes above 7, so they worsen, that automatically generates a new score. Otherwise, we look at it like it's a treatment window. So there's a 2-hour period, 2 to 4 hour period. I can't quite remember off the top of my head, because we've just made some changes based on conversations with our consultant team about what that looks like. So although it can generate quite a lot of alerts, I would say my recommendation is really think about what you consider to be treatment windows, how you want to build that into the system, so you're not getting alert fatigue, because quite often these patients are already now being seen by the right people much earlier. And then also thinking about those patients who are persistent high scorers. So we have built-in systems for consultant-led decisions surrounding the disabling of alertive, so those patients who are end of life or are particularly undergoing a very specific treatment pathway and they're chronic high news scorers, and that the consultant feels that this is not the right system for them. We have built that into our system to basically safety net our staff from alert fatigue, to make sure that they're still able to respond. And as Louise says, you know, part of that, we expanded our service to be able to support that response piece.
Thank you, both of you. So another question from Ian is, have you rolled this out just wide, or is this just in the high care areas? So just to touch on this, we have actually just only rolled it out as a pilot in AAU. We are looking to get the doctors on board before we push this out to the rest of the trust later on in the year, I believe. Anything else?
Correct. No, I think that's it. So we needed to make sure that we picked our highest acuity area outside of critical care and ED to pilot this in, so that we could generate enough alerts for us to get a real feel of like, worst case, this is what it's going to look like, and how do we deal with this, and what does that look like. And actually, for us, the next stage, as Phoebe says, we'll be getting the doctors on board, and we have some good timelines for that now, so that's exciting. And then once the doctors are on board and that is working, we will look to go for almost like a bit of a big bang approach for the whole organisation.
Yeah, definitely, which I think will be super exciting. I was actually lucky enough to be down in AAU the other day, and getting some feedback from the staff was really interesting and really exciting for the next phase. So just one last question. So if you have got any more questions, then please shout up now. Gino has asked, what is the difference between your critical care outreach team and your acute response team?
Go for it, Louise. I know you're itching.
I'm not itching, it's fine. So the setup we had before, our critical care outreach team, was built into our intensive care establishment, so it wasn't a standalone team. So as an organisation, when we were looking at all of our deteriorating patient pathways, so not just the alertive side of things, one of the decisions we made and one of the changes that we decided to do was to separate that team out from intensive care so that we could take a little bit more ownership of how the team was run, what we could provide as a service, because we recognised we needed to be able to increase our capacity for education and things like that across the trust. And then, like I say, we've integrated our hospital at night team into that as well. So we literally just have our one acute care response team now. So we've kept those obviously very close links with intensive care. Our medical support for the response team is still the intensive care doctors. That's still our escalation pathway from a medical support side of things. But within our team, it's not just critical care nurses now. We've got a great breadth of experience in our team. We've got paediatric people with paediatric experience and backgrounds, people with ED backgrounds, sort of acute surgery, and I have to say, it's been like a phenomenal resource having a team that is so diverse with their experience, which has then supported us to be able to go into those areas that we weren't in before. So going into paediatrics, going into maternity, going into ED. Yeah, it's been quite a journey, but it's been a good one.
I think as well, like for us, the change in the model was kind of it was also recognizing that the model has changed as well. Like, you know, I think that we see a lot more high acuity patients in all areas of our organization now. And I think it was for us, it was recognizing that there are other healthcare professionals within our organization who have specialist skills, you know, in acute care, but have chosen not to follow the pathway of a critical care nurse or practitioner. So we were really excited to, like Louise said, you know, broaden our team. You know, the experience is crazy, and for us, as a lot of other organizations are probably finding, you know, implementing of Martha's Rule, you know, we really needed to have a team that had the expertise for pretty much everything, because you can be called to any area, and you know, you need to have really strong phone a friend resources. And that's kind of how we looked at it. It's like, let's create a team that, you know, we can really rely on each other to deliver.
Amazing, thank you. So one last question from Ian. Are you guys actually in Watford? Which I've been on site to West Herts, and they are generally in Watford, near the football stadium, I believe, as I went the complete wrong way. Oh, obviously not a Watford football fan.
You can see the stadium from a lot of our windows. When Elton John played there, we could hear it. If you had the windows open in the hospital, you could hear Elton John playing in the stadium.
That's the one day that everyone wants to be at work,
obviously.
Absolutely. So I don't think we've got any more questions. So just a massive thank you to Lucy and Louise for helping us put this together. Thank you very much to everyone who has attended. If you would like to ask any questions, have a demo from our lovely Tim, or just understand a little bit more around the deteriorating patients, my email address is phoebe.cook@alertive.co.uk, which is on here. So drop me an email. Hopefully I'm actually on holiday for the next week, but it will definitely get picked up. Just a few other things. We are at the Intensive Care Society Congress next Tuesday, I believe. I think it's Tuesday, yeah. So Tim will be there with some of the guys from West Hart, so look out for Tim if you've got any more questions, and we will also be at the HSJ Congress. So again, thank you very much for your attendance, and I hope you all get to enjoy the sun over the weekend. Thank you very much.